My name is Councillor Abigail Marshall-Katung, and I chair the Scrutiny Board for Adults, Health and Active Lifestyle. And just to those who have just joined us, thank you very much for coming. This meeting is being webcast on the council website so that interested members of the public or other stakeholders who would have loved to be here but are unable to be here can actually observe the meeting remotely. So this meeting recording will also be available on the council's website shortly after today's meeting. I would like to now ask board members to introduce themselves, and I will start with Dr. Beale.
Good afternoon, I'm Dr. John Beale. I chair Health Watch Leeds and I'm a co-opted member of this board.
Good afternoon, everybody. Councillor James Gibson, Crossgates and Wimmer Ward.
Good afternoon, Councillor Taylor, Chapel Allerton Ward.
Good afternoon, Councillor Eleanor Thompson, Guiseley and Rawdon Ward.
Good afternoon, Councillor Sharon Burt, Middleton Park Ward.
Luke Farley, Labour Councillor for Bournemouth, Softon, Richmond Hill.
Councillor Winky, Jamali South.
Good afternoon, everyone. I'm Councillor Caroline Anderson, Adel and Wharfdale Ward.
Good afternoon, Councillor Norma Harrington, Wetherby Ward.
Thank you, board members. I would now invite supporting officers to also introduce themselves, please.
Good afternoon, Toby Russell, and I'm the clerk for today's Scrutiny Board meeting.
Good afternoon, Stephen Courtney, Principal Scrutiny Advisor to the board.
Thank you, officers. Right, I will ask Toby to go through agenda items 1 to 5 for us, please.
Thank you, Chair. Under agenda item number 1, there are no appeals against the refusal of inspection of documents. Under agenda item number 2, there are no items which require the exclusion of the press or the public. Under agenda item number 3, there are no formal late items noted, but supplementary information has been submitted in relation to item number 9, elective care hub proposal and draft response. Under agenda item number 4, can I ask members to declare any interest they may have? Take that as none. And under agenda item number 5, apologies have been received from Councillor Iqbal, and I believe we're still waiting for Councillor Hartbrook as well. Thank you.
Thank you very much, Toby. Okay, straight on to agenda item number 6, minutes of the last meeting, and that would be for 21st of June 2022, as well as the 19th of July 2022. It may be helpful to note that the matters arising from the June meeting, page 15 of the agenda. So if there's anything any one of you from the board would like to raise, please, this is your time to do so. We also have a briefing note on the neonatal care on which was only received on Friday, and that's also on page 18, minute 5. So we will not be going into any details with that until we have got further information, because what has come through at the moment is insufficient for us. So we will not be dealing with that in today's agenda. Do I take it that we can approve what you have received as correct record? Is that a nod from all of us? Excellent. Thank you very much. That's for the 21st of June. How about for the 19th of July? Is that a yes? Okay, excellent. So thank you very much, board members. Straight now to agenda item number 7 on Leeds Stroke Services update, and I'll hand back to Stephen Courtney, our Principal Scrutiny Advisor. Thank you.
Thank you, Chair. This report attached to the main report is a general progress on stroke services in Leeds since the board last considered its meeting in October 2021. We have a number of representatives from the Integrated Care Board in Leeds, Leeds Community Healthcare Trust, and also representatives from Leeds Teaching Hospitals Trust Chair. Through you, Chair, perhaps if we could invite those colleagues to introduce themselves, take us through the report, and then to members for questions, Chair.
Thank you. Can I ask all those speaking on this agenda to kindly introduce themselves, please?
Hi, I'm Lindsay McFarlane, Head of Pathway Integration for Long-Term Conditions at the ICB in Leeds.
Hi, I'm David Wardman. I'm currently the Clinical Lead for Long-Term Conditions at the ICB in Leeds.
Hi, I'm Mandy Young. I'm the Clinical Lead for the Specialist Business Unit at Leeds Community Healthcare Trust.
Thank you very much. I do know that we have our officers and exec members here who do not particularly have an item on the agenda, but it'll be nice for you to introduce yourselves and welcome. Great to see you. And I'll start with yourself, Councillor Arif.
Thank you, Chair. Hi, everybody. I'm Councillor Salma Arif. I'm the Executive Member for Public Health and Active Lifestyles. Thank you.
Hi, I'm Councillor Fiona Venner. I'm the Cabinet Member for Children and Adult Social Care, Early Years and Health Partnerships at the Council. Thank you.
Kath Roth, Director of Adults and Health for the Council.
Hi, I'm Victoria Eaton, Director of Public Health here at Leeds City Council.
Thank you very much for coming. I believe we've also got members from the Leeds Teaching Hospital Trust. If you'd like to introduce yourselves, please. Thank you.
Hi, I'm Marissa Minns. I'm a stroke consultant and clinical lead for stroke services at LTH.
And hi, I'm Rob Newton. I'm Associate Director of Policy and Partnerships at Leeds Teaching Hospitals.
Thank you all very much, and you are all welcome. Okay, so back to you now.
Okay, so at a Scrutiny Board meeting last October that we attended, NHS Leeds CCG, now the Leeds ICB, Leeds Teaching Hospitals and Leeds Community Healthcare all committed to developing a strategy for stroke services for the city. We'd previously used the term strategy. However, based on feedback from stakeholders, we've reflected that strategies are quite often seen as 5-year fixed documents with minimal detail on how elements will be delivered. We've therefore aimed to publish a clear vision and with work programmes outlining and tracking the work we're progressing with an assessment of the outcomes being achieved. Development of the vision and priorities document was due to commence in October of last year via the formation of a stroke vision task group. And this was formed last year and meets monthly and includes good stakeholder representation, including all health partners across the city, Leeds City Council and the Ambulance Trust, therefore increasing the opportunity for collaboration and the identification of opportunities to resolve challenges faced in the delivery of stroke care as a Leeds system. While several immediate stroke priorities have been progressed, the work on finalising the stroke vision and priorities document for publication and progressing some future priorities has been delayed due to the impacts of COVID. For example, the Omicron COVID-19 variant has placed capacity constraints on our stroke teams, with clinical delivery needing to be prioritised and non-essential meetings stood down earlier this year, which has meant some of our co-production and design workshops have not been able to take place as we wanted. As identified in the paper that hopefully you've all had the chance to read, immediate priorities have continued to be progressed and have been implemented. And these include the Chapel Allerton rehabilitation ward move that took place in November of last year, with positive patient experience to date received. We've continued the delivery and have initiated new projects focusing on stroke prevention via our long-term conditions cardiovascular disease work programme. And we've also progressed some of our planned patient and public involvement, including development of our overarching vision, joint ambitions and working principles as outlined within the paper. And we've also established a virtual reference group, which includes representation from our local third sector, including the Stroke Association and different strokes. This focused work and commitment as a system to stroke vision and priorities is allowing us the time to place a spotlight on emerging data and health inequalities, enabling us to understand need and where to focus our efforts, therefore adopting a true population-based focused and approach to the work that we're taking forward. The next steps and timelines for developing and publishing our vision and priorities are outlined within your paper, and essentially continuation of our current work over the coming months via the Stroke Task Group. A draft of our vision and priorities document and work plan to be shared via our long-term conditions population boards for agreement in November of this year, following review and agreement by all our partners. And then we hope to publish the vision and priorities in January of next year. Scrutiny members are asked to acknowledge the positive work and priorities progressed to date, despite the challenging climate, and also note the revised timescales as documented. And of course, if you have any questions with regards to the current services, then a number of colleagues are here today to help answer those.
Thank you very much. Okay, and obviously, for those of you who were on the board last year, we did have them in October last year, and it's amazing how a year has gone by so quickly. Yeah, so yeah, good to see the progress you've made so far. Now, I'd just like to hear from board members if there are any comments or questions for them. Yes, Dr. Beale.
I'd like to make a comment and ask a question about prevention. The title of this document is Leeds Stroke Vision and Priorities, and mention is made within the paper about preventing strokes. Fair enough. But it does seem to me, reading it, that there is almost total emphasis on prevention by medication. Now, clearly, medication is important. It's important in terms of anticoagulation. It's important in terms of hypertension. But when we come to one of the other aspects which is mentioned in the paper, that is high cholesterol, it mentions statins, but doesn't mention anything about the other contributory things which are of relevance and which are actually spelt out here. And if I might, Chair, I'll tell a story that happened to me not that long ago when I had a routine health check. And when the results had come through, I had a phone call from the practice saying the doctor would like to see you. So I made an appointment. It was in the days when we could actually see doctors. I turned up and went into the surgery, sat down and was told, it's about your cholesterol level. The computer says that you ought to be on statins. Sorry, why did the computer say I ought to be on statins? Well, the reading, well, I said what was the reading. I was told it was 4.5. Now, 5 is the sort of guideline. I do accept that as you get older, perhaps a bit lower might be helpful. I was 4.5, so I wasn't a high risk person. But what I would have expected was the doctor to say to me, let's talk about your diet. I think that my diet is pretty good. It's comparatively low on fatty substances. No doubt it could be improved. And I just wonder to what extent this work that has been done in producing this has actually talked to GPs to say, how many of you actually do diet with your patients? Do you have a lead nurse or a dietitian who will talk to patients? Because I'm not suggesting the doctors need to spend a lot of time talking about the diet, but I would like to see diet and indeed these other things, smoking and alcohol and so on, but I'm picking up specifically diet being part, an important part of the preventive strategy.
Thank you very much.
Thank you for that comment. Agree fully. We are working to align our focused work on this stroke priorities document with our wider long-term conditions work programme, and also with our healthy populations board within the city. So you're quite right. Physical activity, weight management are all elements that we are focusing on with full work programmes in place. And it's our role, to ensure they align, and we're joining up, working with our local GPs around that and exploring all those avenues for patients, and, using opportunities like 6-month reviews post a stroke to, fully assess lifestyles and, some of the more longer term secondary prevention we can put in place. I don't know, David, if there's anything you want to add.
Yeah, I would agree. And I think when we continue our development of the priorities and vision, that there's got to be clear reference and to lifestyle. There are a number of concurrent work streams that are going on that link really well to the stroke strategy, and we need to make reference to that. So we are increasing, particularly within primary care, the number of social prescribers, dietitians that can offer that extra support to patients. So we're also looking within a work programme that we're undertaking around cholesterol, and looking at where we've got gaps in the city where there's higher cholesterol than there should be, and doing a bit of a deep dive, looking at what's been the causes, what advice has been given already, and what's missing, what's the gap, what are people not getting, and then we've got proposals in there to bolster that with social prescribing and dietitians, because we suspect that there might be a case for increasing the lifestyle aspects.
Thank you very much. Councillor Taylor and then Victoria. Thank you.
Okay, thank you. I totally agree with if name gone now, and John what he says. But on page 31, you have the tech with the doctors. You know, you work with the doctors to identify. But my concern is with the third sectors as well. What are you doing with the third sectors that have looked after the elderly, that trouble with high blood pressure, cholesterol, you name it, they have it. So we have certain third sectors that cater for these individuals. We know that, I'm going back to the BAME community, our culture, our diet is rich. The elderly tends not to listen. When we said that the younger generation, with the food you're eating, you need to change, and so on and so on. So it would be really good for you to interact with the third sector, and also social prescribing, because it's not just the medication or the overweight, cut the diet. We know that we do need activities. We used to do social prescribing, you identify them to sports centers or whatever. What are you doing about that? Because it's not just diet that prevents it, it's everything combined together. But I would personally love you to work with third sectors, because third sectors reach these people more than their doctors does.
Victoria, please.
Thank you, Chair. Just a couple of points to add to what colleagues have said. I think just to, thank you, John, for raising this important point, and for those comments as well, Councillor Taylor. It does feel pretty critical in our work as a city that we do join this work up. I think the first important point is the work led by our NHS colleagues, we absolutely have to join up with the broader work that's happening across the council and the city, including third sector colleagues, because the NHS can't do this on their own. So there is something about making sure we continue to join this up. But just to assure colleagues, public health teams are working very closely with NHS colleagues, but we know this will be a major priority coming out of COVID. From previous discussions with this board, we do know that one of the major impacts of the pandemic is that much prevention work has been paused in primary care at national directive. So we have a backlog that we're working through in terms of not just a NHS health check, but other prevention and early management of risk. So we know that this has slipped. We know it's not where it should be. And as a city, we've got a plan to get that on track, but it is an urgent priority. And we are starting to see some of the effects of that coming through in terms of numbers of people, affected by conditions that could have been prevented earlier on. So just to assure the board, it is a major priority. We need to absolutely join it up with the wider work across the city, and link with the causes and the risk factors further upstream. So not just smoking, healthy weight, physical activity, alcohol related risks, but also some of the causes of those causes about inequalities in communities. So we will be prioritising that work as we move forward, and happy to update on that as we go. Thank you.
Thank you very much, Victoria. That's comforting to know that it's urgent priority for us. So that's really good. Thank you. Councillor Burke.
Thank you, Chair. I have two questions really, but Victoria's partly just answered one of them. And that was about the link to this research. And you do mention health inequalities. And sometimes it's always mentioned, isn't it, without the level of detail under it to make it meaningful. So I just wanted to ask you what that looks like in reality. And the other thing is the pilot you're running in West Leeds, which I think looks really, really interesting, because the stress all the services are under. I really like the idea of people having more responsibility for some of their own testing wherever possible. And I think that by giving people, where we can, more responsibility, that works out. To give you an example, I have regular blood tests because I have polythysemia. So it's a pain and you can't get there and you have to make appointments. It takes too long. I can only have them done at the hospital. So I would love to be able to do that myself. And I know it wouldn't be fit for everybody, but I know this is around cholesterol, but perhaps testing of a wider nature in communities is the way to save resources and make people more aware of their things, and perhaps a deeper look at the genetic factors that contribute, because we talk a great deal, don't we, about the other contributory factors, but genetics plays a huge part in lots of the so I think that's and my final part is the post-stroke care. Again, my experience of it, it's a bit hit and miss, and I think that's fair, depending where you are and depending how good the care team you're allocated to. So perhaps there's a piece of work there, because prevention's important, but we all know strokes will unfortunately still happen. So the post, so that we could have a uniform level of care right across the city. Thank you.
Thank you very much, Councillor Burke. Will anyone of you like to respond?
Thank you for those comments. In terms of health inequalities, we're working with our public health colleagues and business intelligence analysts to really drill down into our stroke data available that's all published nationally, and really drill down into our cohorts of populations and where they live, to understand the needs and perhaps some of those more earlier preventative kind of interventions that we could have put in place to learn from those. So that work is well underway, and we've tried to give you a feel within the paper as well, around a graph there demonstrating the variance within the city in terms of the prevalence of stroke as well. So just to say there is a lot of support to this work and analysis underway. As you say, we're piloting as well projects, and a lot of that work is in conjunction with David's pharmacist team within our organisation, and as you say, an awful lot to learn from that, and via this work we'll keep that alive and sharing back what we're learning and you know how we're able to develop that further going forwards, and again the learnings as well. Also to say as well, I guess in terms of our citywide health inequalities agenda from a Leeds ICB, the organisation and the city is taking forward lots of health inequalities projects. We're working to roll those out currently, again working with a lot of local care partnerships, where they will have the local third sector kind of working with them. So we're looking at ways to, you know, pilot new initiatives and ways of working, and, you know, hopefully learn and inform new ways for the future. That is all underway, and we can share further details of that.
Thank you very much. Councillor Taylor.
Sorry to come back. Victoria speak about COVID, the aftermath behind COVID. But can we also remember today we are in cost of living, and it's the poorer is going to be suffered. And a lot of them diets will gone off rail now. So I'll urge you to look at health inequality, but look at those that really needs it, because people won't be eating properly. People won't have money to do the things they do. And that alone brought on stress combined with everything. And that's where it all comes in. So I just think I know you said there's a lot going on, but where are you looking? Are we looking at the bottom? Are we looking at the top? And I just think we should work in the deprived area more and look for those individuals that will struggle more, that don't have anyone to talk to, especially we talk about migrants coming in who don't understand English and don't know where to go and what to do. Those people, they are human and they are also a part of society, and we need to focus on those individuals. But I do ask you to look in the deprived area with the cost of living coming on.
Councillor Anderson. Thank you, Councillor Taylor.
I just want to carry on the prevention theme. It says here that many people do not always take their medication as prescribed. Why? Is it too complicated? Is it just can't be bothered? Don't they understand the instructions? I mean, and we need to make it easier for people. Why are we making it so complicated? If we know they don't do it, what is it that they're not, why are they not doing that? And has anybody done any research behind that to find out what makes it so difficult for people? And then the other thing, it says, oh, well, we'll hand out some blood pressure monitors to everyone. Well, if people can't take medication, they're not going to monitor their blood pressure. If you give them a machine, it doesn't mean they're going to actually do it. I mean, I have a blood pressure monitor in the cupboard, but I couldn't tell you how long it is since I actually used it. So, you know, are we wasting money there, really? There is a lot. I mean, we should probably be handing out recipes for how to make healthy food, or that might just be as good.
Thank you, Councillor Anderson. Yes.
Yeah, it's an interesting point, because I think it is multifactorial why people don't take their medication. And a lot of that can be down to their perceptions of their medication, whether they feel the medication's doing them more harm than good. And that all starts with education around people's conditions and how medication works and how it helps. So we're hoping through having more pharmacists now working within general practice, undertaking something called structured medication review, where we can pick up some of the concerns that people have around taking medications and address those. So through the sort of pilot work schemes that we're doing, we're trying to get under the skin to find out for particularly for anti-cholesterol reducing medication and anticoagulation. We know in particular through national research that there are particular areas where there is poor compliance, to really understand what are the barriers and specific local barriers that there might be to taking those medications as prescribed, and then providing education and support for our pharmacy professionals that are working in primary care to be able to pick up these barriers before prescribing a medication and address them, because the most expensive medication is the medication that's not taken. And just like to, if I could just pick up on the bit around inequalities as well, because that's really important to me as clinical lead, and it's something, you know, we chose to put this data in to highlight around inequalities. So I think traditionally we know that within the NHS we can be fairly reactionary sometimes, particularly over the past 2 years with COVID, where it's been all hands on deck. So I think looking at inequalities is a key line of inquiry for us moving forward. And I think particularly if you look at stroke, what's interesting, if you look at pure numbers of stroke, most strokes happen in our older communities, tend to be more affluent, because stroke risk just increases with age. Actually, what we're showing here is that if you take age out of the equation, more strokes are happening in our younger, more deprived communities. So it's a real key line of inquiry that we want to get more data on and understand our communities and where there's inequality.
Thank you very much. Councillor Farley and then Victoria. Thank you.
Okay, thank you. I suppose my questions are really kind of around the current state of stroke response. And I appreciate obviously there's nobody from Yaz here to talk about blue flashing lights. But have we seen any, or do we plan to make any changes to this strategy with regards to obviously the changing context around responses? I know, and well, there've been reports obviously at a national level that strokes have been deprioritized as ambulance waiting lists have gone up. So has there been any thought about that in terms of the strategy? And I suppose again, this is more of a Yaz question, but perhaps you guys can touch on it. Yeah, is there, obviously across the NHS, we're always looking for new and different ways of working, with the workforce acting to the top of its register and its banding. Is there potential for, in particular stroke cases, I know at LTHT, the brain attack team did a lot of work around thrombolysis, to empower and train paramedic teams to deliver thrombolysis? I don't know if that's a possibility.
So we'll try and take those questions together. So I wouldn't want to speak on behalf of Yaz, obviously, and don't want to prejudge or preempt it. One thing to note, I guess, for Leeds teaching hospitals, our ambulance handover times are very low compared to others. So that means that there are less patients waiting in ambulances outside our emergency departments than the vast majority of other trusts. So that's one performance indicator that we're doing well at, and that obviously helps to support a quicker response time. But regarding Yaz's strategy for response times and what that is, I wouldn't be able to comment on that now. I don't know if you could comment on the brain attack team.
We don't have any current plans to look at delivering thrombolysis with the ambulance service. I think our focus is on getting people to the hospital as soon as possible, because we have a number of hyperacute treatments, and all hyperacute treatments rely on you having a brain scan first. So unfortunately, that would be a major barrier to delivery in the community. You need to have a scan of someone's brain before you can give them thrombolysis. So I think it's about getting them to hospital as soon as we can. But our response times with ambulance handover, we wait for the patients as they arrive. They're pre-alerted to us. So our brain attack team are usually at the door waiting. And our time to scan is really good compared to national figures.
Okay, thank you very much. I believe we can also write to the Yorkshire Ambulance Service directly and get some answers for you, Councillor Farley. Thank you. Victoria.
Thank you, Chair. It was just to come back on the inequalities point, and it feels important to make the distinction between how we work with NHS colleagues to make sure that there are inequalities addressed through healthcare. So the fact that all communities have good access to healthcare and good quality healthcare that is culturally appropriate, etc. So there's a huge agenda around addressing inequalities in healthcare provision that obviously we work closely with colleagues around, which works alongside the broader work as a city that we do, knowing which people are most at risk, and how we work with communities with a really broad range of partners, as Councillor Taylor's highlighted. All of the learning from COVID around not just delivering one size fits all, because that doesn't reach all communities, but really working in those very broad supportive ways to keep people well in communities, which is all of our jobs and the public health role of the councils included in that. So I think when we talk about inequalities, it's making that distinction between that access to healthcare from different communities and the broader work around health inequalities and keeping people well. So again, I think there's continued work to do in making sure all of that is joined up. to fully complement all of the work that's described in this paper. But just wanted to bring that out really on the inequalities question. Thank you.
Thank you very much, Victoria. I'll take the last comment or question from Councillor Burke, so that we'll move to the next item. Thank you.
Thank you, Chair. I probably need to stop following you, Victoria. It was just linked to the inequalities and how strokes and other diseases will affect particular groups. You know, Afro-Caribbean, for instance, diabetes linked to stroke. And I just wondered if there was any plans to work with those particular groups, partly because of the reason Councillor Taylor highlighted, but it's genetic, isn't it, because of other things. If you had any plans to work with those particular groups?
Yeah, so we know some of the risk factors for stroke have different prevalences in different ethnic communities. So people from Afro-Caribbean backgrounds are more likely to have hypertension, which then puts them at increased risk of stroke. So I think through some of the work we're doing around hypertension, we're specifically focusing, we've got a specific focus around particular communities where we know are at higher risk. So I think it's about and similar with diabetes, you're more than 3 times likely to get diabetes if you're from a South Asian origin. So we've got that as part of the diabetes strategy. So I think in terms of that prevention work, yes, definitely an increased focus around different ethnic communities.
Thank you very much, and thank you for all the updates. And obviously, we've been on this with yourselves for a year, and we still look forward to more updates and progress on this particular agenda item. So thank you very much for all that you've done so far. Right, moving swiftly, agenda item number 8, Leeds Community Neurological Rehabilitation. I tell you, the medical industry and their words, you've got to go back to school to learn. Okay, I'll hand back over to Steve to introduce that item for us.
Thank you, Chair. Yet again, fairly brief from me, Chair, is this report introduces a further update from NHS colleagues in relation to community neurological rehabilitation services, which the board last considered also in October of last year. So the more detailed update is provided in the appendix. And also, just to confirm, at Appendix 1 is the feedback this the board prepared in response to that initial consideration back in October 21 for information, and the update is provided in Appendix 2. And in terms of presentation, we have the same presenters as last time, Chair, with the exception of Leeds Teaching Hospital Trust, Chair.
Yeah. Thank you very much. Yeah, this is also ongoing for us. So back to yourselves.
Thank you. And just to give apologies as well, Helen Knight, who is the clinical lead for the Community Neuro Rehab Service, is unable to join us today. So I know Mandy's in attendance and will help as best as possible with any questions. So we attended the Scrutiny Award meeting last October to summarise the emerging themes from an extensive engagement, including staff, patients, carers and wider stakeholders undertaken last year on how we redesign our specialist community neurological rehabilitation services in Leeds for people living with long-term neurological conditions like MS, Parkinson's, stroke or traumatic injury to the brain. Subsequently, the model as outlined in figure 1 of your paper was designed, which includes 6 key priorities for implementation to address the themes identified and discussed with this board last time we met that had emerged from our engagement activities. These include the provision of an assessment and referral function and a rapid 48-hour response pathway to manage and facilitate self-referrals, and a more responsive service in order to provide rehabilitation in the right place at the right time for the patient. A core home first service offer, enabling care closer to home, therefore increasing accessibility. An extended rehabilitation service offer and bespoke specialty pathways for those who need a more tailored approach to ensuring an offer of personalised care. And continued access to some inpatient rehabilitation with the provision of 1 inpatient bed when needed, following the recognition that fewer inpatient beds are needed based on demand and need analysis undertaken. On this basis, the decision has therefore been made to withdraw the 5 inpatient beds from the estates at St Mary's permanently. A significant benefit of the model is that all patients referred will be seen within 2 to 4 weeks if urgent and 12 weeks if routine. And this will reduce variation in practice whilst enhancing patient self-management and personalisation. The model was agreed by the Leeds CCG governing body in January of this year, following the completion of an equality and quality impact assessment on the model and the options selected. And implementation of the redesign will be completed in phases as outlined within your paper over a number of years. A number of work streams and project groups have been established by Leeds Community Healthcare to mobilise the redesign. As with our stroke work, there have been delays to this work, mostly due to the Omicron variant of COVID and the capacity constraints on our teams. And these delays have been shared, communicated and agreed with our long-term conditions population board. And a number of workstream updates are included within the paper. I'd like to highlight that clear communication and engagement has continued in relation to this work. Following approval of the model in January, communications and engagement began with staff within the service to inform the case for change, essentially the HR process that has had to be worked through, whilst also forming a staff health and wellbeing work stream to monitor this and offer the right support as and when staff require this during the change. In addition, you said we heard a resource was prepared for patients as recommended by this board, and current patients of the service have been kept up to date with service changes throughout, with the service's website reflecting the current service offer. And current patients and any patient entering the service has also received a letter regarding the current service offer and what to expect. Phased implementation of the new model is expected during Q4 of this financial year, following some further planned discussions on the model with our long-term conditions population board, with consideration of staff feedback and data to inform the best uses of our resources and the Leeds pound. And you said we did report will be published at this point, outlining the new service model and ongoing satisfaction from the service, which we continue to collect. Again, you're asked to acknowledge the positive work completed to date, and also the priorities that we've been able to progress despite the challenging climate. Thank you.
Thank you very much. And I'm pleased to let you know that, yes, we have acknowledged your positive work. Thank you very much for that. Members, have you got any comments or questions? Yes, Councillor Gibson.
Thank you, Chair. Just a couple of questions. Maybe go through them individually, or I'll ask 2 first and then you can answer them and I'll ask my third if that's okay. Yeah. So what tertiary specialist rehabilitation services are there in West Yorkshire? And second, what integration is there with adult social care? So is there a social worker attached to it or as part of the MDT, for example? And I'll come back to the third question after. Thank you.
In terms of tertiary specialist services, we've the Chapel Allerton specialist kind of neurological services delivered by Leeds teaching hospitals. So I guess the community element of this works alongside that provision, and obviously our core specialist neurology services within Leeds teaching hospitals. So our neurology teams work closely together there. In terms of wider, I guess, community rehabilitation, my understanding is that's very varied across West Yorkshire. We've got this good service offering in Leeds that we're looking to improve and enhance. But I couldn't fully describe, the offering across the rest of West Yorkshire in detail to you. Can certainly share some of that detail post-meeting if that would be helpful. Mandy, I don't know, is there anything you'd like to add?
I haven't got anything further to add. I think it is something that we need to take away and investigate and then come back with further information.
And what about the question about social work as part of the MDT? Integration with it, or more further integration with adult social care?
In terms of adult social care, are you able to answer that one? No. Again, I think that's one we'd need Helen to give more of a response on, because she leads the multidisciplinary teams within Leeds Community Healthcare.
I think that's really important. I mean, the first question about tertiary services links to the question that I'm just about to ask now, actually. But I think it's really important. I mean, if we're going to have joined up services, especially with adult social care, given the rehabilitation service, I mean, it should be very joined up, shouldn't it? You know, there's such an overlap between adult social care and any rehabilitation service. That,
I think.
Oh, Fiona, sorry, Kath. Yeah.
We do have a number of specialist social workers, and I'm just racking my brain to remember whether or not we've got a specialist one for stroke. But even if we don't, we have what we call a complex needs team that will be reaching into all of these sort of specialisms. So if we haven't got I'll have to go back and double check whether or not we've got a dedicated stroke worker, but if not, it'll be the staff that are in the complex needs team that would reach into things like neuro rehab and stroke.
Thank you. Is that?
Yeah,
Are you satisfied?
Third question.
Go on.
Yeah, if that's all right.
Yeah, it's all right.
So the question was about the it looks to be a cap. Now, I'm not entirely sure whether it is a cap on the amount of sessions that that somebody can have. So it mentions within the agenda pack that people can have up to 6 sessions. Now, but it also mentions as well under 2.3 in the agenda pack and the item as one of the targets that there should be clear outline and criteria of what the community neurological rehabilitation services offers available to all stakeholders. So I'm wondering whether or not you've decided to cap it at six sessions, or whether or not you've just decided to make clear what the offer is, because I'm not sure what it is because of the it's not clear in the pack. And following up from that, so I did a bit of research about what's happening in this field sort of across England, and it talks about a postcode lottery and people patients not feeling that they have enough sessions to meet their rehabilitation needs. And there was a report in 2020 from or it was a joint report actually from the Society of Physiotherapy and the Royal College of Occupational Therapists, who surveyed just over 1,000 patients and with long-term health conditions. Sorry, I'm tongue-tied today. And it said that just 29% of the patients that they surveyed said that they received enough rehabilitation. So what have you decided to cap it, or have you always had it at 6 sessions? And do you think that those 6 sessions is actually enough to meet the needs of people, given that in this Leeds special, I suppose, is Leeds offering, is it a better service offer than what the rest of the country has? I mean, you've already suggested that we might be doing a little bit better than the rest of West Yorkshire.
I'll attempt to answer that one, if that's okay. So we're currently delivering 6 sessions over 3 months. That's the current interim offer. Under the new offer going forwards, we'll be looking to move to 8 sessions over 4 months. And that's through, I guess, the evidence, well, that's been determined through the engagement with the clinical teams around what's best, and also a review of national best practice that Leeds Community Healthcare have led on to make that assessment. Previously, the offer was quite open-ended, and we had people who might have 1 or 2 sessions, and some members who'd, I guess, be on the in the rehabilitation programme for a number of months, even years. And so we are, I guess, looking to, I guess, set expectations as someone joins in terms of a length of programme, and a really defined programme. However, then as part of the model, we do have a re-referral and re-access route whereby people can access additional kind of therapies as and when required. So there is that ability to re-access service going forward. So that's what we've tried to design there to ensure a good quality service for more people that is accessible, and individuals are all be seen more timely because we're able to increase the throughput of patients into the service, within the financial resource that we've got. Mandy, I don't know whether you'd like to add anything there.
I think, thank you, Lindsay. I think you've articulated really well what the new plan is, but I think it's also, we need to identify that although we've got a plan, this will be continuously reviewed with patients providing input to look at how it may need to be modified and moved as we go along. I think the reason for putting a system in place like this is we did have long waiters and we had patients who weren't being seen at all in a timely way. Hopefully this will address that. And so they will be seen in a better timing.
Final comment, okay.
You have my sincere sympathies with the budget constraints that you have, but it seems to me that you've traded off, haven't you, between seeing as many patients as possible as quick as possible, and having, or perhaps seeing fewer patients and longer waiting lists but more sessions. And I understand why that you've done that, and perhaps that is the right thing to do. I'll be very interested to see what the patient feedback is on that, especially given the report, as I mentioned, that was published in 2020, and that the main concern being that they don't actually receive enough rehabilitation. I can understand why you've done it, but I think patient feedback is going to be absolutely crucial to that.
Thank you very much, Councillor Gibson. So I do know Mandy and Lindsay, we do have some feedback coming back, isn't it, in terms of some of the questions that haven't been answered. Do not forget that. So thank you very much. Dr. Beale, did you want to say something?
Thank you, Chair. Yeah, thank you very much. It's great to see the home first approach. It's great to see the collaborative work you've been doing with patients and with the third sector. They're all very great, and I would certainly support reducing the number of beds from 5 to 1. But just 2 or 3 questions around that in detail. Firstly, these things never come singly. So to have 1 bed, sometimes there'll be no one who actually needs it. And the next day, there'll be 2 people who urgently need it. Presumably there is some flexibility built into that. So those who need a bed can actually have access to a bed. Secondly, you talk about out of area referrals, a small number per annum. Presumably you're working closely with any localities where they tend to refer into our area from their area, so that they can look about how they develop or change their practice, which fits into the treatment which they have asked us to provide in the past. And thirdly, you can bet your bottom dollar there will be some people who describe reducing from 5 beds to 1 bed as cuts. How are you going to answer that question?
Thank you. In terms of the, I guess, the sourcing of the bed, we're currently working through that currently. Leeds Community Healthcare are, and we're exploring options for that. And as you say, one of the challenges there around, I guess, the planning and frequency of the bed needs. So we are exploring options for that bed provision, and we're confident there will be a solution for that. I don't know, Mandy, if you want to add anything there, but that is all being worked through in terms of procurement kind of details and next steps around that. In terms of out of area referrals, again, we work closely with our West Yorkshire colleagues and have kept them informed of the position of this service and the position on out of area referrals. My understanding from Helen, our clinical lead, is we've been very clear on communications, and any kind of referrals that have been sent through inappropriately, despite the comms they've managed prior, onward discussions with the other relevant clinical teams. And that has been well managed. And actually the number of referrals have been very, very small, I think just a handful. And finally, your first point with regards to, I guess this being seen, could be seen as a cut around a reduction in beds. Again, we're working to ensure we get the communications right around this, especially with patients around, we've got a financial envelope and we've specified that within the paper. We're not taking away from that, we're not removing that, but actually we're able to, in terms of value, deliver a greater home first offer through that disinvestment in the bed base and reinvestment of that resource into more therapy staff members to deliver care closer to home for people. And then those who truly need the inpatient rehabilitation offer, an offer will remain for them. We'll communicate that clearly. And then, via our long-term conditions board as well, we've made the commitment around continuously reviewing the offer, the feedback we're receiving, I guess in relation to the earlier point made. But also, we're using this opportunity to really understand our referral numbers into the service, the time people spend in the service, the outcomes being achieved, and also demand and need to really build that case for the future in our long-term conditions board and also our integrated care board going forward. So well aware there may be an ask, and highly likely there will be an ask around financial investment, around how we further develop these services, but we are doing all our best to really, I guess, achieve the best to our ability within the financial resource we've got available to really evidence value before we ask for more resource. And I think this is a real, positive example of how we are truly maximising the resources that we have got available currently.
Thank you very much. Any other questions from members or comments? Okay, thank you very much, Lindsay and the team. And we do note the timescales in terms of what you have sent to us in the information that you've given to ourselves. So that is definitely noted, and we know that they are revised as well from what we had last year. So thank you very much for that. Okay. Agenda item number 9, elective care hub proposals and the draft response. Back to you, Stephen.
Thank you, Chair. As outlined in the paper, Chair, this item is on the agenda to give members the opportunity to feed into and give comments in relation to Leeds Teaching Hospitals Trust's proposals to establish an elective care hub, a planned surgery hub at Wharfdale Hospital, and the related changes to endoscopy services at that same location. As the paper sets out, members have received details outside over the summer, outside of the meeting, through a briefing paper from Leeds Teaching Hospital Trust, and members also received a first update around the development of elective care hub at Wharfdale back in February 2022. So the proposal is to give members the opportunity to provide a response by the deadline that's set out in the paper, which is the 22nd of September, so this coming Thursday. Outside of the agenda pack and supplied to members electronically, there's a draft response that members have received, and members each have a hard copy of that paper available now. As I say, that is draft, discussed with you, Chair, in advance. So if members have any specific comments or additions or amendments to that, that would be very helpful to receive that now. And subject to any changes that members may wish to raise and agree, the proposal is to agree that that draft response as the board's response in order to submit that to the trust chair. Happy to take any questions.
Thank you very much. Any questions? That's the document, and I believe you all have got that. So if there's anything you would like to say, add, take out, amend, just let us know. We've got until the 22nd Thursday, but would prefer if we can agree today, please, if you do not mind. And don't you start reading it now because you've had it. All right, thank you very much. Sorry, can you use your microphone, please? Thank you.
I have no comment, it's fine, but Chaplalton, I only live across the road with parking. So apart from that, it's brilliant.
Thank you, Councillor Taylor. Anyone else? So do we take it that you have agreed to these proposals then, board members? Fabulous. Thank you very much. Stephen, back to you.
Thank you. Thank you, Chair. So item 10, local authority health scrutiny additional guidance. As outlined in the report, members received an update around the Health and Care Act 2022 and the likely implications in relation to health scrutiny back in its meeting on June 2022. Also gave a commitment at that meeting to provide members with additional guidance as and when that became available. And back in towards the end of July, the Department of Health and Social Care published a range of guidance, including some guidance on health scrutiny principles, the details of which are outlined in the paper, Chair. I don't propose to go through all of the details that's presented, maybe just to pick out a couple of specific things to highlight. So just in terms of who the guidance is aimed at, just in paragraph 7 on page 69, it specifically highlights that the guidance is for leaders from across health and social care, identifying they should use the principles to understand the importance of oversight and scrutiny in creating better outcomes for patients and service users and ensure they're accountable to local communities. Largely, the guidance doesn't really affect the underlying powers of health and overview and scrutiny committees. The one difference being that the referral power is being replaced by a power to intervene by the Secretary of State. The details of that are still yet to come forward, so that we still are in that intervening period where both processes are allowable. The guidance also makes it very clear, and perhaps the clearest it's been stated for some time, around that the changes to the new models of care are likely to inevitably, I think the guidance says, Chair, lead to changes in how and where services are provided. Except that this guidance is has been drafted and is prepared as national guidance, so there may be some local flexibilities and local impacts that need to be reflected in that, but it's perhaps useful just to members to be aware of that specifically. And also the specific mention about joint health scrutiny. So members of this board will be aware there's a discretionary committee, West Yorkshire Committee, that was established back in November 2014, and that has been in situ during this intervening period until the Health and Care Act was agreed. So then the guidance kind of emphasises that joint scrutiny is likely to be something of greater significance over time. So I won't add anything else, Chair. I'm happy to take any questions or comments, but obviously the recommendations are set out in the report for members to agree or not, Chair.
Thank you very much, Stephen. Members, any questions on the guidance? It's clearly set out for us if you've had time to read through it. I take it we're happy? Yes? Excellent. Okay.
I'm happy with the recommendations, Chair.
Yeah. You all happy with the recommendations as well, yeah? Can you smile? Yeah, that's great. Thank you. Right. Okay. We're doing very well with time. You all will be pleased to know. You all know that time is very important to me. So we won't just keep you for keeping sake. So we're now on to our work schedule, agenda item number 11. Back to you again, Stephen.
Yeah, thank you again, Chair. Again, I won't go into the report in great detail. Members have received this within their information pack. The updated work schedule is attached as appended, as is the analysis of the potential work items that was presented to the consultative committee back in July. A couple of things specifically to note. The report identifies the progress that's being made around dentistry and bringing forward an item for the board to consider. There's no further update to be provided. I'm still waiting for details to come back from NHS England and the West Yorkshire ICB in relation to that, and we'll discuss that with the chair and members in due course. And also the addition of the concerns that Health Watch have raised around access to orthodontic services for children, which again members made reference to in the pre-meeting. Secondly, specifically around preparations for November's board meeting, which is been identified to focus on the workforce strategy and waiting lists and times. Some draft areas of scope are presented for board members to consider in preparation for that meeting. So again, any specific additions or amendments to that scoping work would be helpful. And last but not least, Chair, just around the mental health inquiry that was proposed by the board. The report sets out a number of developments that and strategies that are in place around mental health, and identify some of the work that the board has previously considered. So in relation to that, rather than presenting some draft terms of reference to the board, it's proposed to hold a scoping workshop with members of the board to discuss that in more detail and specifically identify those areas where the board may add greatest value. So with that, Chair, I'd take any comments or questions from members.
Thank you very much, Stephen. Any comments or questions on our work schedule? Okay, and I'll kindly ask, do we have, Councillor Thompson.
Just noting with interest the reference to mental health and neurodiversity. It's a thread that keeps coming up recently in terms of housing, public transport, women and neurodiversity in particular, and the barriers they face. Thank you.
Sure, thank you very much. Councillor Farley.
Sorry if I'm missing something. Do we have any intention of bringing in NHS partners and colleagues from across the council and public health to discuss winter plans? We're facing a very difficult winter right across the country, so it would be, I think it would be wise for this board to look at what the plans are across Leeds.
Through the chair, thank you, Councillor. It's not specifically identified on the work schedule. Clearly, the work schedule is the board's to determine. I guess the issue may well be looking at the work schedule is what the board isn't going to do to release the capacity in order to do that. And clearly, that's a discussion and decision for the board chair. But clearly, there's no reason why the board can't. It's just a matter of timing and the capacity for the board to do that, Chair.
Obviously, I appreciate the discussion we had around the work of the board earlier in the year. However, I'm just very conscious that we are coming into we've had a very difficult few years across the NHS more generally. I think the very least we could do is perhaps request winter plans from the ICB and the main providers within the city, and how they're tying in with the council.
Thank you very much. I mean, we do have the ICB coming in is it October's meeting, Stephen?
Yes, Chair.
Yeah, so I mean, there are some things we can actually ask the question and see if that could be added into the presentation, and we can talk about it on the day by all means, because it's definitely very, very important. So thank you for highlighting that. Any other questions or comments? Yes, Councillor Hutchinson.
Yeah, it's just to say that possibly the November meeting, you're looking at the whole system impacts report on waiting lists and waiting times and workforce strategy. So it might be that there could be a section on the winter plans in that meeting because it would all tie in together.
Excellent. Thank you very much. Brilliant board members always give us brilliant ideas. Thank you. Any more? Councillor Berwick.
Thanks, Chair. Just around the October meeting with the oh God, can't speak. I think I've got it from you, James. Implications of the commitment to Leeds becoming a marmot city. Obviously that's something we all welcome, but it's quite huge, isn't it? So perhaps that overlaps some of the other work streams. So rather than it being a standalone, we're going to become a marmot city, it can be linked up to the other bits that we're going to look at throughout the year.
Yeah, definitely. We've got Councillor Venner here. Whenever I hear Mammoth City, I just see her face. So definitely, I'm sure we'll be able to get some input when we come to November's meeting. Anyone else? Oh, wow. Amazing. Okay. Thank you very much for all your contributions and support today. To all our speakers and partners who have attended, we're truly grateful. And we have come to the end of our meeting today. You've got lots of time. So no playing, go back to business. And we look forward to seeing you all. 18th of October is our next meeting. So thank you all very much. Truly appreciate it.